So I'm happy to call our meeting to order. Thank you all very much for being here and joining us. Jeffrey, if you would take the roll, please.
Bishop Michael Badger.
Present.
Ronald Bennett.
It's not.
I know. Reverend Mark Blue. Ronald Chapin. Jonathan Dandies.
Here.
Darby Fishkin.
Present.
Kathleen Grimm. Sharon Hansen.
Present.
Michael Hoffman.
Present.
Christian Johnson.
Present.
James Lewicki.
Present.
Christopher O'Brien.
Here.
Jennifer Persico.
Present.
Jack Quinn.
Present.
Gino Rusi.
Present.
Michael Seaman.
Present.
Benjamin Swannekamp.
Present.
We have a quorum.
Thank you, Jeffrey.
Welcome.
The minutes have been included in your packets, unless there are any additions, deletions, or corrections. Are there any? I'd be happy to entertain a motion to approve them as presented. Is there such a motion?
Second.
Motion been made and seconded. All in favor?
Aye.
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 And to contrary, motion carries. Let's go right to the really the important part of our meeting. Well, two important parts. The first important part of our meeting, which is our budget presentation. So, John, if you would.
Sure.
Just to let you know, Reverend Blue has also joined.
Thanks, Jeff.
Can you kick it off, John?
Yeah, go ahead, Tom.
Okay, so just to kick the budget presentation off, I'd first like to thank the executive team for all the work that they did on this budget. As you can imagine, these are very, very challenging times. And they really did a great job of working with our managers and our physicians to come up with a budget that I think is financially responsible, but at the same time meets the needs of ECMC and the community more importantly. So as much as we would love to have gotten the budget back to zero, it's very, very difficult to do that without cutting essential community services. So our goal here was to cut the deficit in half and then look to 23 to see what we could do with regard to revenue, but also obviously expenses. So that's what the budget will be presenting today. But again, I just want to thank the executive team. They put a tremendous amount of work into this budget. And I think it's a responsible budget and a budget that invests some dollars back into our facility and into our people, which is obviously very important right now. And I think in the long run, we will continue to be strategic, as we discussed at our strategic retreat, in the efforts we make to continue to raise revenue and look at our cost structure. So with that, I'll turn it over to John.
Okay. Thanks, Jeffrey. Just go to the next, actually to the second slide. Yep, right there, you can stop. Okay. Thanks to everyone, and I think, first, just to echo Tom's comments, to thank the executive team, Andy and the operations team, Dr. Murray, Karen, and the entire executive team, quite honestly, really did spend quite a bit of time. We did change the process a bit this year, really did try to more fully engage our management all the way down to the manager level in this budget. Really important to do so. As Tom said, we really tried to seek continuous improvement. On the screen right now, you can see the goals that we really sought to achieve as part of this budget. Not different really from last year per se, other than really when you look at the operating loss, to cut it in half. So $15 million operating loss in the budget. I think I may have said last year at this time, none of us are comfortable budgeting an operating loss, but it's a necessary step in a stepped approach to recovery from 2020 and really 2021's financial realities. It's a 55% improvement from the 2021 projected operating results, but at the same time, we're able to maintain the quality of care provided, critical services that are provided, enhancing the patient experience through an investment in digital health, and really some of those platforms, complying with our bond covenants, which I'll talk about in a moment, but again, really prepared the budget to accomplish these goals without significant job actions. Next slide. So this slide and the next are really just reminders of our requirements around the regulatory requirements and process we have to follow. No real changes here for these two. We did follow the same process, and like I said, no changes. Next slide. Process I did talk a little bit about as a reminder, just as we go through this process, kind of starts in June or so, and then culminates through our review with the Finance Committee that we had last week, and then today's review with the board. No significant changes, like I said, in the process. Next slide. We thought it'd be important to just historically show the board and remind the board and those who are new board members, give you a little bit of history on our trajectory. Pre-COVID, you can see here on the revenue and in our operating margin, we were increasing revenue year after year while maintaining and slightly improving on our operating margins until the COVID interruption in 2020, which you can see here was staggering. Significant drop in revenue, significant drop in our operating performance. But it's important to note, as we've kind of talked about the stepped approach to recovery, you can see the growth coming back on the revenue side for 21, 22, and then again projected out into 2023, but also those improvements in the operating margin, as Tom said, cutting it in half from 21 to 22, and then really seeking to eliminate that loss in 2023. Our key financial ratios are really the culmination of the operating plan. So I won't go into too much detail here other than to call out two items. One, our FTEs. As Tom said, we did continue to seek to reinvest in our people. You can see an increase here in FTEs from 2021 to 2022, and it's actually a larger increase than that because we're actually running lower today than the 3482 that's projected in the 2021 column. And then the other item I'll note is we're getting back on track. If you can see here, our debt service coverage ratio, excuse me, in 2020 was below our 1.1 requirement. You can see it projected for 2021 and then 2022. We are projecting to surpass our requirement. Next slide.
And that impacts the bond covenant, doesn't it?
I'm sorry?
That impacts the bond covenant?
Yes, those are,
ratio?
that ratio is the sole remaining financial ratio for us. It's administrative ratio, as we've talked about, that we're required to keep. So the statement of revenue and expenses in the budget, as we've mentioned, is a $15 million operating loss. It's 55% improvement from 2021's projected. We've done that, again, without adding CARES Act funding, and really with a focus on an increase in and really a focus around labor and our clinical areas, and then a focus on reducing costs in non-clinical areas. So you can see here an increase in salaries and wages, an increase in investment in physician and resident fees, with corresponding decreases in supplies and other expenses. I'm going to go through just some high-level assumptions that we'll talk through. The first, and you can go on the next slide, is volume. with the last couple of years being very sporadic and somewhat unpredictable, what we aim to do in the budget 2022 was keep it really flat to 2021, but really pick several months of full operations in 21. And so what we've done is try to keep that flat, if you will, with an appropriate level of conservatism. It does assume a fully operational platform, so no significant COVID interruption next year in the budget. We do have some increases in behavioral health inpatient cases as well. We did take a hard look at average length of stay, although we haven't talked about it yet today. We will. This is an area where we have seen increases, market-driven increases to some degree. And we'll talk about that more, but we took a conservative approach here without reducing it significantly from year to year. On the outpatient side, we do have declines from year to year in the budget. The primary reason for that, and it really is driven as a reduction in COVID-related testing, COVID-related vaccine administration. I'm just not expecting as much in 2022 as we saw, especially in 2021. On the surgical side, we are seeking in the budget to increase both inpatient and outpatient back to levels that make that really account for the first 2 months of the shutdown of cases in 2021, January and February, as we talked about, with a shift from inpatient to outpatient in surgical site of service that we've continued to see. The last one I'll mention is because of some community closures of certain psychiatric services, we have increased our CPEP visit counts to accommodate for that. And interestingly, excuse me, these are leveling off right around the 2019 levels as we look at the 2022 budget for the CPEP. So that's more of a pre-COVID look at our CPEP area. On the revenue side, I think it's important to note that we are seeking and included a 2% net increase in rate before cuts. That's, of course, not that high. We'd love to see that higher, but that's really the result of the net of all of our payers, commercial payers being higher and our Medicare and Medicaid payers being lower.
So John, that's a blended rate?
That's a blended rate. And that's before any significant cuts that were made. We did see in the budget and included a cut from Medicare in disproportionate share for Medicare, about $4.5 million.
And we're currently in negotiations with some private payers right now, so.
We are.
That's not conservative, but pretty responsible number in every year.
Yes, yes. Yes.
Who is our number one commercial in terms of volume? Is it Blues?
Blue Cross. Yes.
Followed
by Independent Health for true commercial, but Fidelis is really our largest Medicaid commercial payer.
where are we with the Nationals, United?
It depends if it's because now a lot of Medicaid and Medicare are privately managed, so it depends on the category.
Okay.
Medicare, United's picked up a lot of Medicare in the market.
They have. They're all the Nationals are a relatively small component of our business at this point. Yeah, I spoke about the volume a bit already. The revenue cycle process improvements, we're continuing our process improvements in that area. In 2021, you may recall we had a $10 million incremental improvement in the budget We've been working our way along with that very well, actually. So we're in line to achieve that. This $5 million is incremental to that. So we're looking to continue the processes that we've really put in place. Again, this is a mix of internal and external, where we are, pressuring the payers, working on language, really trying to improve our operational relationship with them in order to make sure we're getting paid for the services we provide.
How are we doing on denials?
We've actually seen some reductions in denials.
Yeah, especially COVID helped with that piece of it. I think that's continued on a little bit, but make no mistake about it, as we come out of, and have less of the COVID issues, I think it'll ramp up again. The governor just approved an executive order around authorizations from insurance companies. So that's gonna help us with inpatient and making sure that we don't kind of get it on both ends. We are authorized to do what we're doing, but I don't think it had anything to do with denials at this point. So it's strictly authorizations. But we've seen a little bit of they took their foot off the gas a little bit on denials for a while, but it's starting to ramp up again a little bit. So.
Yeah.
Just a quick question, Dr. Murray, are you seeing your colleagues behaving?
Yeah, in general, yes. One of the things that becomes contentious is around an admission, whether it's a true admission or often the insurance will try and knock it down to an observation. I think actually the performance, particularly when there's peer-to-peer, is actually very good at actually fighting back and achieving.
So that
I think
initiative,
I think our physician advisors are doing a good job.
so that initiative is working, it appears to be.
Yeah.
Great.
That and once we get it to an appeal, we are winning fairly high percentage of those appeals once we get there.
But we're not losing them on the basis of incomplete records or all that other
I mean,
nonsense.
there's always room for improvement, but I would say it's more on the insurance companies with regard to, clinical differences.
Yeah, one areas that we have to work on is the surgeries, because we do, the surgeons tend to bring cases here that actually do require admission, even though some of them, many of the surgeries now can be done ambulatory. Medicare introduced that with the idea that some patients can go home, not that every patient should go home, but the insurance companies interpret it that way. So that's where we have to work with our surgeons to make sure the chart reflects why the patient needed to stay overnight as an inpatient and couldn't go home on the day of surgery. I think that's one of the areas that we're working on at the moment.
So that's still hanging out there as a something.
I think there's room there that we might be able to improve.
Okay, great. Thank you.
Quick question, is revenue cycle management handled internally or is it outsourced?
Yes, no, everything's handled internally. Yes. Any other questions before I? Okay. On the expense side, we really did see just our typical type of inflators. And as I mentioned, an increase in FTEs. We have our union and collective bargaining agreement wage step adjustments. Again, a blended average of about 3.5% with the steps. We did include our termination dates, or our expiration dates, if you will, of our 3 largest contracts. Just for your information, for those of you who may not have been aware, we do include an anticipated staff premium cost. Staffing availability obviously is a large risk right now as we speak, so we'll talk more about that. But hiring into 3,500 FTEs is certainly going to be challenging as we get into the next several months. Next slide. One of the notable increases in really investments that we are including in the budget is an increase in physician costs and resident fees. We've highlighted a few here, and I think what I'll do is ask Andy if you could just give us a rundown of some of the major increases there.
Sure. And thank you, John. On the in terms of the increases that we had, I would probably say Apogee, who handles our non-teaching academic services, the highest one. They've been a really good partner, but we've expanded a lot of different zones. If you look at think about the old ER was a zone that we didn't have before. They cover that. They did 12 zone 1. So, and making sure that the coverage model is indicative of what's in the market. Usually hospitals are somewhere between 1 and 16 patients per day. And we also beefed up some of the staffing with UPP, which is our behavioral health provider, and then obviously recruiting new surgeons. We have a new thoracic surgeon, Dr. Quaquish. That's part of our Great Lakes Cancer Care Strategy, where we were able to, if you remember, we had Roswell covering for cardiac thoracic because of our trauma designation. That'll go away, and now Dr. Yaron Perry, who was recruited by BGH last year, we went into with the intention to recruit him, and then another one, which was Dr. Quaquish. Dr. Quaquish's clinic is here. So, and then obviously transplant's been tremendously busy this year. We're probably going to do in excess of 160 transplants. That means we'll do it next year, but certainly we have investments in that we really needed. And again, continue to try to beef up like ID, GI, and certainly oncology.
Andy, what's the number, the projected number on renal?
Don't transplant about 160. Yeah, I'm being conservative, but 160.
And if you weren't being conservative?
Well, if you look at the number, they're like gonna try for 180, but I don't think they'll probably slow down. So depends on what day you talk Dr. Kaler, but I'm almost stay with the 160.
And just from and that's for 21.
21, yes, for 21. For 22, I think we did like 140.
Yeah, we're a little more conservative next year in the budget itself. And all of those investments in the new physicians that are more strategic in nature, we've included the appropriate revenue side of that and volume related to those physicians. Contractual fees and purchase services, we have our typical increases, but we do have some strategic increases, whether it's IT security, some licensure issues, but also we've got some of our equipment within our ED that's coming off a warranty, so we had to make sure we had enough coverage there. But also this is where you'd find, it's not noted here, but our investment in our digital health platforms and the services related to that. There's about $1.4 million of an investment related to that.
That's all tech.
Yes. Yeah, tech services that kind of sit, on top of our systems that will enhance the patient experience through various different digital health platforms.
Are the reimbursements the same? Are they digital?
Telehealth visits is what you're asking.
Right now they are, because they currently have the benefit of some of the waivers that have been issued by the federal government. But in the future, we don't know. We don't know yet. Whether or not that will stay
At that level.
Yeah. Okay, so on our supplies, you saw some decreases. We did build up inventory in 2020, 2021, as mandated by the state. Those are at some premium costs. We were able to reduce some of those costs going into 22, and the inflationary increases that are included, we were able to offset in most part with savings initiatives, whether it's value analysis related to physician preference items, pricing, joint contracting through Great Lakes Health and the like. We do a very in-depth review each year related to a pipeline involving Dr. Murray, his teams, Karen Szymanski, her teams, the folks through Great Lakes, also at Kaleida and the joint contracting teams to really pinpoint opportunities. And there's about $3.5 million of saving opportunities in 2022's operating plan.
Two questions, perhaps this is for Joe and or Andy, maybe Councilor Calucci. Have we been made whole on that big bonfire that we had?
The bonfire, you
You wanna get it, Joe?
No.
PPE.
You're all looking at
The
one
warehouse.
another, which
No.
means
I said, maybe, I look at that guy.
I don't
Yeah,
know.
He's a little Count Nichols.
The answer is no, not yet.
We haven't been made whole as far as I know. We actually
Claims
said
been
we've
made, it has
whole
been
on
their money,
PPE.
right?
Oh, okay.
Claims been
Processed.
made.
It's been processed, yes.
Claims been made.
We haven't seen the check yet. Last John saw it today.
We haven't seen a full check yet. We did receive a partial payment.
No reservation of rights or qualifications yet?
I don't know that.
You would know it, right? We would get a lot, we haven't gotten a letter like that, right? Okay.
And so I'm assuming that the new warehouse or inventory place has got a sprinkler system?
It's, we're gonna divide
Just
it.
saying.
We're not gonna put all our eggs in one basket this time, so we're gonna spread it out.
We have 3 locations that they will go to.
And will the 3 locations have sprinkler
Yes.
systems?
Make sure of that.
No, they do.
I know it's a sensitive subject. So,
It's not as sensitive as it was when it was.
just what I would ask.
There was an increase in our depreciation, but it's really a function of primarily the accounting change for leases. So it's a reclassification from lease expense into depreciation, about $5 million. That's driving that increase. Next slide. Given the step recovery, obviously we have limited capital availability, but what we are doing is increasing the routine capital spend from 2021, where we were at $5 million, to a spend of $8 million, and then reserving about $10 million of dollars for non-routine type capital spend. These are some examples, although not limited to these, that we'd be looking to if we needed to carve out capital for the operating room enhancements, along with philanthropy, of course, Kensington Heights or Grider Street enhancements as well. Those dollars will come from operating funds, so no borrowing in 2022. With every budget, we've got obviously performance improvement opportunities and risks. A couple of those that I'll highlight here are, of course, length of stay management. We have probably significant opportunity there, although we're hamstrung a bit by the market right now in terms of what's going on in the nursing facilities around town with their staffing issues, congregate care facilities, and our just lack of ability to place patients. But I think going into next year, that will probably loosen up a little bit. So there's opportunity there.
John, I have a question in regard to that. With the lack of step-down capability in some of the nursing facilities and patients having to stay in-house much longer, increasing obviously length of stay, the question I have is, are you seeing a strain in terms of DRG burn, and how are we compensating for that in the event that patients are overstepping the designated DRG?
So I'll tackle it, anybody else can jump in. We're eating it. So as you know, Jim, when we are forced to have these patients stay longer than necessary, we pay for it, and it's been an age-old issue for us. So there's really no assistance, if you will, from any of the government payers or the private payers around that. So it's a challenge for us, for everybody else. We have, usually around 20 alternative level of care patients. We probably have over 30 right now. And that's just the people that are designated as alternative level of care. There's others that are still in the hospital waiting extra days to be placed. So it's a challenge, and it's not just, it's nursing homes, but there's also developmentally disabled individuals. There's folks with mental health, behavioral health issues. that need to go to certain settings that can handle their conditions. So it's a combination of a lot of things and other social placements, but that, you know, it has gone up. But to answer your question, again, it's a cost to us.
Right. Okay, thank you.
So there really is no other option.
No, there's no other option.
I mean, I think that's the point.
Yeah, I was gonna say that this topic is probably for safety net hospitals like ourselves, is like a burning platform, because we really get the sickest of the sick, and it's harder to get them placed in other spots without any reimbursement from the government. Makes it really challenging, and we've seen over the last 3 to 4 years, all of the state agencies who have conjugal group homes, etc., reduce their beds, and so which has created much more issues, for us. And I think also COVID is probably the average length of stay for a COVID patient between 17 and 20 days. And when you think about that, and I would say if you hear we say we have 25 COVID positive patients in the hospital, we really have 50, because when they turn negative, it's not like they leave the next day like the flu or the pneumonia. They're going to stay for another week or so. So all those things from a safety net hospital perspective of us getting and having a high Medicare and Medicaid population is really, it hurts us financially compared to other suburban type of markets. Not throwing a shot at the suburban hospitals, but that's just the reality.
Also
Yeah.
affects.
Andy, just another quick question relating to that to some degree. With some of the smaller outlying hospitals, especially the rural ones, where they're obviously being impacted at perhaps a greater level with some of their needs and the departments shutting as a result of workforce exit, are you seeing a significant higher rate of access to our facility, where those hospitals don't have capacity to care for patients and they're sourcing them to us?
Well, I would probably say, if you'd asked me this question probably before this week, I would say, yeah, we're starting to see more from the rules. We've stopped ICU transfers, so we haven't seen as many of them come from the outlying areas. But I think this is going to be, as we continue to move forward with how the mandate is, I think it's just going to be very challenging for rural hospitals to be able to sustain census, have enough of the doctors out in those areas, which means they got to transfer into your more urban areas, and we're pretty much all crunched now for beds. So I think the rules are going to struggle over the next foreseeable couple years, and I think you're already seeing rules struggle throughout the country because they have the same problem that most people in rural markets are highly Medicaid markets.
Also affects the surgeries too, because there's no beds for certain surgeries also.
Yeah, so that's why we'll talk a little later. We stopped the inpatient, elective surgeries because we needed those beds for folks.
Kind of getting back to the budget a little bit on those performance improvements. We still have our accelerated excellence improvements going on throughout the facility. Length of stay is a part of that. We have reviewing our efficiencies in OR right now. Trying to do that, and obviously our specialty pharmacy implementation so far is going well. We put some revenue in the budget around that. Really excited. The Trellis has really hit the ground running. So I think going into 2022, specialty pharmacy will really be good for us. I think the team, our executive team, has done a really good job on the vacancy management piece, controlling as much as we can. Obviously, we still continue to use overtime, but we're trying to make sure most of all of our hires have been really at the bedside in terms of that. And then, there are many of us, Keith, Tom, myself, and others that continue to work with some of the payers around population health strategies. I think it's still something on the docket for us as opportunities as we move forward.
Then the next slide is with any budget, we've got risks, obviously, and other emerging issues that are, things to monitor as we go into 2022. The first and foremost is really what we've been dealing with as we've talked about the last several weeks, and that's the staffing availability. But also, we always have and are monitoring the federal and New York State reimbursement systems and whether or not the targets that they always look at in terms of cuts will remain. So those are things that we'll continue to monitor. The only other thing I think I'll mention is the market-driven risks. So it really is code for what's going on in the market and what's happening in the nursing homes, congregate care settings, because those really do have backups all the way through, from discharges all the way back to the ED and the visits and our ability to care for the patients all the way through the system.
John, real quick on the federal side, if we breach the debt ceiling on the 16th, have you heard anything from Treasury about how to prioritize Medicaid, Medicare payments or against other payments that are going to be coming due?
I have not heard anything new on that.
Just curious how they're, Social Security comes first or Medicare. I don't know, but
Are we expecting to?
that's what Secretary Yellen said this morning. If they don't move, yeah.
And typically what's happened in those instances is they do that and then it gets settled and it gets released. But to your point, it could be an issue for us.
Right. That's well above and beyond the
Right.
midnight on the 30th. That's
Right.
a whole different nightmare.
It's a whole different.
Is unprecedented.
Right.
Yeah.
Yeah, in prior shutdowns, they've prioritized Medicare payments and Medicaid payments, although I will say in the past we have seen delays in Medicaid payments.
Right. That's what I'm talking about.
I think that's almost guaranteed come
Whether it's a week, 2 weeks, a month.
on the 30th. Yeah. But
And the
after the 15th or 16th,
They always pay, it's just
delayed.
sometimes it's delayed. Yeah. I think the next slide is just a question slide, so I'll stop there for questions. But I'll conclude just by saying that, again, I think there's an appropriate level of conservatism in the budget, while at the same time being able to accomplish the goals that we set out, maintaining quality services, as well as achieving our bond covenant, doing so without impacting and really taking significant job actions.
Yeah, John, Jim Lewicki here. Question with regard to the shortage of workforce, and obviously it obviates the need for, in many cases, hospitals are using per diem and locum tenens type situations. Obviously, we're a unionized institution. How does that work in our setting? And in many instances, some of these per diem and locums people are really getting premium wages that perhaps might supersede what some of our people are getting. How do we work through that? But also part of that I'm interested in is how much do you anticipate, that will drive up our overall labor costs because having to, fill the gap with those types of individuals?
So I'll start. First of all, we don't like it and they don't like it. We don't like paying the money and they don't like seeing folks come in that are making more, right? So it's kind of unfortunately at times a necessary evil. And I think, they understand that we have vacant positions that we're recruiting very aggressively for those positions. And really when we end up, and we do very little compared to a lot of other institutions, but when we do bring folks in, it's because it's an urgent situation. And nothing that we like to do long term. So Joe or Karen or anybody, if you want to add to that, but I think that's, pretty much the sentiment in the building. And, hopefully, and right now, let me just make another comment. Right now, agencies are just, folks are just through the roof because, other states are paying upwards of, $130 to $150 an hour. So it's the supply and demand dynamic has gotten out of control. Typically, an agency staff is going to be around $65. So just to give you a sense of what's going on.
I'll talk a little bit about the travel nurses.
Yeah, that's what I'm talking about. Those are the travel folks. Those are travel nurses that are $130 to $150 an hour. So.
Plus expenses.
Yeah, plus expenses, right? Correct. Plus you got to put them up.
Yeah, that's compared to what Tom said less than a year ago, where we would pay normally $60, $65 an hour.
Right now, we're saying no to all of that, but it's getting hard. So, and there's other places that are paying that.
Hey, Tom, with the governor declaring the state of emergency, will there be staff needed, from the military at ECMC? And if so, how are they being paid?
So they would be, paid by the military, but We right now have told the state that what we really need are nurses and certain like emergency room techs, that level of person. So whether they come from, to your point, the National Guard, Sharon, or they come from an agency that the state's willing to pay for, or New York City, or overseas, whatever, those are the folks we need. So we have had that discussion, and I know that over the next couple of days, we're gonna have more discussions. I was gonna talk about this a little later, but we offered incentives to our employees to work extra shifts, and that is working. They are picking up those extra shifts. So right now in the short term, it's working well. I just get concerned about the long-term sustainability of that because, folks have been working really hard through this entire pandemic, and as we are trying to recruit. And, there's just a reality to the long-term sustainability of people working, more shifts than they normally do. So that's why we need to work with the state and continue to recruit as best as possible moving forward.
Other questions?
You indicated that there were about 5% of the ECMC staff that was put on leave, and then there was 20% at Terrace View. Are all of those nurses or are other employees included in that?
There are other employees included in that. The breakdown, if I remember correctly, was about, on Terrace View, I think it was about 80 clinical, 20-ish non-clinical, somewhere 10 to 20. On the hospital side, I believe it was about 150 clinical, does that sound about right? And about 26 non-clinical.
Other questions on the budget specifically? And I want to be sure that we maintain our commitment on the WBE, MBE purchasing. Does the budget reflect all that?
Oh, yeah.
We have a pretty aggressive group that continues to watch it every month.
And actually, we're up for an award from the state for our efforts.
So Diane Arteri and Nick and Serena have just done a fantastic job. And we're actually hosting a seminar here for MWBEs. So it's going really well, I think.
Okay, questions, any further questions specifically on the budget that John has presented? So at this point, I would entertain a motion
John?
to.
Just to let you know, I'd like to thank my colleagues that have participated on the finance committee. As John stated, we met with the executive team and reviewed the budget, and it comes as a unanimous recommendation from the finance committee to support the 2022 budget.
Great, Mike, thank you. Then I'm going to assume the chairman of the finance committee, Mike Seaman, would have made a motion to approve the budget as presented. Is there a second?
I'll second.
Second, Jen Persico. Any further conversation, discussion? Anybody online? All in favor of approving the budget as presented, please signify by saying aye.
Aye.
Aye. Aye.
There's always a delay.
And
As long as I'm mute, don't.
See, I'm learning. And to the contrary, the motion carries. Thank you, everybody. John, great job.
Great
Andy,
job,
thank you. Executive team, thank you. Tom, as always.
Thank you.
Well done. So now we start to ask questions. When are we gonna break even?
I hope 23, but there's so many moving parts right now, that it's hard to promise. Our goal.
I do think it, and the reason we included, and once again, for the record, I want to be sure that the board recognizes that up until the COVID pandemic, the hospital was on a rather extraordinary trajectory to not only break even, but make some money. And then this thing came out of wherever it came out of, and we're now playing from behind on all of it. But to that point, we're doing great. So, and we're still doing great, given what we had to work with. So, well done, you guys.
Thank you. Thank you for the board's support. Appreciate it.
Dr. Murray / Dr. Cummings. Or should I say Dr. Cummings / Dr. Murray?
You have the minutes, you've been provided with the minutes for the August and September Credentials Committee, which processed 35 initial applications and 73 reappointments and 11 resignations. It tends to be a busy time of the year. There's usually turnover on the internal medicine area, which is where we saw most of the recruitment. We also added an otolaryngology surgeon, Dr. Stanovich, who's going to be working with Dr. Laurie on cochlear implants. 2 urologists who will bolster our reconstructive urology service, and a breast surgeon, Dr. Pizer, who will be working with Dr. Frey, also in plastics, building the breast surgery program. Otherwise, I would beg the board's approval of the minutes.
Motion made by Dr. Murray, is there a second?
Second.
Dr. Grimm, further discussion? Seeing none, all in favor, please signify by saying aye.
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 And opposed? That motion carries as well. Before I ask Tom to talk about his report, I do want to recognize a member of the senior management team who celebrated a very special birthday today, and for whom I think in the hour that I was down there, everyone in the hospital at one point came through to wish Sue Gonzalez a happy birthday, which included everything from her picture on Oreo cookies to her picture on M&Ms to any number of pink flamingos, slime dogs, mulberry grill, meatballs, and on and on and on and on. So, Sue, happy birthday.
Happy birthday, Sue.
Happy birthday, Sue.
Happy birthday, Sue.
Thank you, everyone.
Okay, Tom.
Okay, thank you very much. We obviously are dealing with the vaccine mandate. I don't know if my presentation's up yet here. I got questions.
I know.
Pushing the button. See, she's gonna have, I knew that was gonna happen. I knew that was gonna happen.
You said you were
I don't
pushing
know why
buttons,
you
you were
do
just pushing the
Oh,
wrong
okay,
button.
all right, got
Happens
you.
all the time.
Knew that was gonna happen. All right, so, obviously been dealing with the vaccine mandate. This, again, back to Sharon's question earlier, this is where we stand, today. We have 176, employees on unpaid leave in the hospital, out of a total of 3,303, so approximately 5% on unpaid leave. And in Tara's view, it's a little less than 100, I think it's 93, on unpaid leave out of a total of 474, so about 20% on unpaid leave. As I mentioned, we do have some folks that are presenting vaccination cards and are actually getting vaccinated, but it's not been, it's been kind of slow coming. The week before, we had about 156, I think it was, people get vaccinated, and about 51 over the weekend prior. And a bunch of other folks present cards also. So that's our total to date is about 7% of individuals on unpaid leave. So some things we did to prepare for this was we opened our incident command center. As you know, we suspended elective inpatient surgeries, medical ICU transfers, reduced some units at Terrace View to prepare, and many other nursing homes are doing the same thing. Reduce some hours at our outpatient clinics so that those individuals could report to the hospital to help on the inpatient side. We also had administrators who have clinical degrees come and help, as well as ask some retirees to come back. And we significantly incentivize employees to take extra shifts, and that did work. And in fact, actually, some individuals even came and got vaccinated so they could take advantage of that.
Talk a little bit about the timing of the elective surgeries and the ICU transfers.
Yeah, so we, about a week ago, when I sent up an email to the board, we had our highest census at 553 individuals, highest census ever, with 56 people waiting in the ER. And that was really a result of all the congregate setting in nursing homes, anticipating the staffing shortages and shutting down units. So we knew that we were obviously going to have less individuals. We predicted 10%, it ended up being 7%. individuals be unvaccinated and be on unpaid leave. So we started doing these efforts to make sure we're prepared for that. These started Monday, and we're monitoring this. Today, we were just notified that Mercy has gone on diversion as a result of their labor negotiations. So we will probably continue these efforts through next week because of that. We were thinking we might be able to make some changes because we do have the remaining employees taking extra shifts. But as with Mercy doing that, it probably will be unlikely because we're gonna end up getting a certain amount of admissions per day with that, and we've heard reports that they need to decrease their census by as much as 100. So we'll see.
Would you please explain diversion?
Yeah, diversion means they're not taking patients in their emergency room. The place that kind of distributes patients, if you will, for lack of a better way of describing it, is called MERS, and they are looking at how they will equally, appropriately, point patients to emergency rooms across Western New York right now.
Are they gonna go right to the Catholics, to the other Catholics?
No, I think there's going to be a combination of, for instance, stroke care going to the GVI or something that may be more trauma related coming to us, or so they'll triage those based on patient condition, location, and those types of things.
Who's gonna manage, I'm sorry, Tom, who's gonna manage that?
It's a central emergency management system called MERS. I can't remember the exact acronym right now. Maybe Charlene can help me.
It's Medical Emergency Radio System.
Thank you very much. Thank you very much, Matt.
So it's a system that does that?
Yeah, these are the county ambulance dispatchers under Deputy Commissioner Greg Gill.
Got it, that's what I was looking
For
for.
the emergency services.
And they help.
And that covers the MAC is also on diversion too.
Yeah.
So it's significant in the middle of what we're dealing with, and we put out a communication in addition to this, saying to folks, if you're going to come Monday, it's going to take a certain amount of time to get cared for, and now this will be across the community. When we did that, it actually did work. I think people chose maybe to go to an urgent care instead of an ER and those types of things. I know there was some ER increase in the community. Some urgent care increase in the community. So that message did help. I think there's going to be more messages from more institutions saying the same thing because it's just a community-wide, obviously, issue at this point. So
I haven't seen it. Have they made that public yet?
they sent out a press release today.
Today?
Yeah. So
Congressman Quinn, you better tell your friends in South Buffalo to be prepared.
Good. So with regard to COVID patients, let you know where we stand. Here's where we stand to date with some of the some of the statistics. You can see we've done obviously the length of stay has gone up a little bit here in 21. We currently have 25 patients in house. That's been about where we've been at for the last couple of weeks. It dipped a little bit. It's ticked up a little bit, and you see our percent of vaccinated employees. And just to let you know, our vaccination team continues to do great work. They were here all this past weekend trying to make sure we get folks vaccinated. And just Casey Davis and Lucia Rossi and that team are just been rock stars. Congratulations to Donna Brown, Donna Jones, and Karen Zemansky for being in the Business First Power 200 award winners. Congratulations to them being recognized in the community. Also, a couple other individuals that were recognized. Cindy Bass was recognized in the Black Achievers Awards. Lise Kaler in the Women of Influence, and Lucia Rossi in 40 Under 40 for Business First.
That's great stuff.
Yeah, it's nice. And we continue to say thank you and honor our team here at ECMC. I just wanted to point out some individuals who received recognition over the last couple months here. And you see Emily, Michelle, Leandra, and Maria. We have our Tulip Awards, so we're recognizing outside of nursing individuals who are crucial to the care that's delivered here. So Maria was honored in environmental services.
What did Leandra get?
Daisy Award. She had a Daisy Award. Sorry, I didn't mention that.
She's spectacular.
Yeah,
I mean, they're all spectacular, but she
was very emotional. She was very
She
emotional.
is
So.
absolutely
Yeah, she's very, very good. And just a reminder that Daisy Award is, award from patients. And they get nominated throughout the hospital, and then they're selected once a month. So it really is special for the nurses, especially because the honor is coming from patients, and they read the patient nomination, and it's always very emotional for everybody because, as you know, our nurses do unbelievable work here at the hospital. I mentioned our busiest day at 553 patients, and we continue to have a very high census, although not that high. And I'm sure over the next few days we're going to have to monitor, make sure we don't hit those levels again. Charlene, Dr. Murray, and Karen had vaccination WebExes for the entire building. And as you can imagine, they received a lot of comments, mostly by folks that did not want to get vaccinated. And I want to thank them for their efforts because they had to take a lot of comments from individuals. I'll leave it at that. But I want to thank them for doing that because it was a little contentious at times. The SNUG program received the Buffalo Outreach Worker Award, and again, the SNUG program continues to do great work around preventing violence in our community. Some of our statistics for the past month here. As you can see, we are continuing to do well with regard to our hospital-acquired conditions. If you look at our CMS actual in June, we did have a few catheter-associated urinary tract infections, but our central line infections were actually at 0, which is unbelievable considering how sick people are. We still have some COVID patients. And C. diff we had 2, and then all the other patient indicators for June were all 0. So pressure ulcer, surgical complications, post-respiratory failure, and perioperative pulmonary embolism. So really very, very impressive, and we continue to strive for 0. Our patient experience scores, we're continuing to work at them. You see that N number there, 685 versus 880. We're continuing to try to get those numbers to be at a little bit higher level. I think with all the waits in the ER, the inability to get patients out of the hospital, this is really, it continues to be tough because you're telling people things they don't want to hear. And that they can't be treated in a timely manner necessarily all the time, and that they can't get out of the hospital when they want to get out of the hospital. We'll continue to monitor this, but I would imagine these numbers are very similar to what's going on across the country and around the state.
Tom, share with the board the leaving numbers at the.
Yeah, that's a very good point, John. I did not mention that. So last Saturday, and this has come down, we had a 27% left without being seen number in the ER. So basically, 1 in 4 people were walking out, which is obviously scary, frankly, because individuals came there because they felt they needed to be treated. Hopefully, they went and sought other levels of care. That has gone, and that was about 20% for about 3 or 4 days, which is why we made some of the decisions we made to decompress the building. That's down to between 5 and 8% recently, so that's more manageable numbers. Usually that's a number that, as Andy knows, Karen knows, I'm all over to make sure we get that as close to 0 as possible, but it's really difficult right now. So, but those are numbers we absolutely never want to see again.
And typically, where do they go?
I don't know. Karen, are you on the line?
I don't think we honestly know. Obviously some of them are patients who may have come in with a relatively minor issue that wasn't urgent, but that's not always the case. Some of these people are actually sick and just don't want to wait. And they may go home and then eventually end up coming back in again. Some go to urgent care, but the problem in our area is there's no real convenient urgent cares in the area to go to. Most of the urgent care in this area.
Tom, have we? Obviously we hear and get the information on a regular basis. Are we messaging that why they're waiting? Because when you think about it, we built a brand new ER. It's bigger, it's better, and then we're in a position where we're not taking patients when we thought this would be resolved. So is it being messaged in the
Yeah,
community,
and
especially
that's
our
what
own
happened.
communities?
Yeah, that's what I
that
mentioned
people-
earlier. We messaged it heavily, and
Okay.
people heard us because our volumes went, which is, good. I never thought I'd be in a place where we tell people not to come.
Right.
But we were at the beginning of last week, and we were, Andy did a lot of interviews around this, and we were all over the community saying, it's going to be 8 hours Monday. We also put up signage in the ER, and actually, I was down in the ER. I think it was either beginning of last week or end of the previous week, talking to Dr. Mankin. He was, pleading with us to do that. So that's why one of the reasons we went out and did that and told people. So it worked. I mean, people really, I think, either went to alternative levels of care or waited, or I don't know what they might have done. I mean, hopefully called their primary care doctor.
We don't exist.
It's working. So.
Do we utilize online check-in?
Yes. So we do. We have virtual. We also pointed people towards using our virtual system, and we're continuing to push that. And we're going to back to John's point about the digital health platforms. We're really going to push that more this next year coming up. And I think that as the ERs become more wait time, I think more and more people will take advantage of that. And actually, we're working on a program right now where when people come in, we can actually give that to them as an option, a virtual visit. Right. They can do it right there. So that program is being developed also.
I think it's important to share with the board as well the reality of between the vaccination mandate and the issue relative to Mercy and the Catholics, that number and that issue is going to go up, at least in the short term.
Right.
Right?
Correct.
So our average wait time could be 8 hours or longer, correct?
It could be, again, yeah, unfortunately, yeah. I think that's what we're facing in the next couple of days.
Okay.
Tom, Mike Hofford, wasn't there a system put in place with the new ED where patients were going to be essentially triaged to like 6 different areas for treatment to try and cut those wait times down, and we still have this overload? Can you comment on that?
Yeah, it's just a demand issue, right? So if we had the old ER, we'd really be in trouble. So that's the kind of patient volume we're seeing. So people are still being triaged, Mike, and appropriately. We have 3 different units that have different levels of acuity, but it's just the volume has just been through the roof. So that's being done, and I think, like I said, had we had the old ER, it would be twice as bad in that regard.
Yeah, I was going to add, I think kudos off to the emergency room staff because of COVID, etc. Essentially, one of those pods is essentially a med surg area, and we live it every day. I will say, thanks to Tom and the team's leadership, I feel like probably the first time in my career when we made the moves we made last week, I think the hospital appreciated us taking those steps because the ER was just becoming a very, very tight situation in terms of being backed up, left without being seen 4 or 5, 20% 4 or 5 days in a row, people in the bench, people in the hallway. And I think when we start making those moves, that support has actually, I think, helped us culturally this week with people taking the shifts that we're kind of in this together. So I think it'll be, it's a move that's going to, hurt some financially, but I think culturally for us, it was a good move.
Yeah.
As someone that was in the ER last night until 4:30, by the time I left, it was pretty much empty. When we got there about 11 o'clock that morning, or actually about 4 o'clock, it was pretty full. So they did a great job of taking care of patients during that time period.
Thank you, Bishop. Appreciate that. And I just wanted to mention, because she texted me, Karen's on the line, but for some reason her computer's stuck. So she wanted to comment, but we've been trying to get together and have some more events to make sure our ECMC family loves to gather, and it's really important for the work we do here and to have some time together. So we did have some events over the last few months. We highlighted our DE&I work here at ECMC and had a diversity fair, and Cindy Bass and her team did a great job with that. We had our WellFest event, and it was really, really well done. We had a lot of vendors, a lot of food trucks, and it's just really a time to remind people that they need to take care of themselves and to be able to take care of our patients. We also celebrated National Hispanic Heritage Month and had some events around that, and it was a really well-attended event. These are just a couple other things that we have done to recognize our ECMC family. We had our golf tournament this year, was sold out again, and a great day.
Seaman.
What's that? Yes, thank you, Chairman Mike Seaman.
Thank you, Sue
Chairman
Gonzalez.
for life. Chairman for life. He can never not be chairman of the golf tournament. And they did a really nice job. And Sue and her team did an exceptional job. It was just a great day. Yep. There you go. Smile Cookie. We did this with Tim Hortons again. This year raised $135,000. That's a lot of cookies. This is all the Tim Hortons from all across Western New York supporting ECMC. And thank you, Sue, again for your team's great work on that. And Peter also for promotion around it.
3 dozen of which are still in my trunk.
If anybody wants to. We had Fred Jackson and Daryl Taylor come and say hello to our patients and our employees, and it was a nice morale booster. We appreciate those 2 guys coming around and saying hello. We had Marcy Danny's Memorial Family Bike Ride. Thank you, John, and to you and your family for supporting ECMC and Connect Life every year with this event. It was very well attended. Mr. Seaman was there, and we had a really, really nice time, and it was a very nice day, and Marcy was smiling down upon us.
Great weather.
It's great weather.
Yes.
I just, in the midst of everything we have going on, and Sue and her team have just done an amazing job raising money. Sue, I'm going to turn it over to you in a sec to talk a little bit about our biggest event. But we have, really, they've done a great job. And there's actually more than this that I have listed here, which Sue can talk about a little bit, because they've been doing pop-up raffles, as you all know, and pop-up online auctions and those types of things. So, Sue, I'll turn it over to you, and you can talk a little bit about our biggest event and what we have to do this year.
Thank you, Tom. Well, unfortunately, I have to start by saying we're disappointed to have to say that we do have to postpone Springfest for the 2nd year in a row. This is due to the Erie County Building indoor mask mandate for events. We have decided that our new event date will be Saturday, May 14th of 2022. We'll push back out to our original time of year. This is already our 5th postponement of date in the past 2 years. And it is very disheartening to lose this kind of revenue for a 2nd straight year for the foundation. This event does gross over $1 million in one evening each year. And that's all support that comes back to the hospital for patient programs and care and to support the front line. But I think my team's done an amazing job, as Tom said, at the foundation. They have worked tirelessly since January 31st on over 37 fundraising events in the past 39 weeks. And as of today, actually, with the Smile Cookie money in, we are now just over $630,000 in those 39 weeks, which is over $16,000 a week, which isn't easy to do. But my team's been amazing, and I'm very proud of their work. And we are really looking forward to focusing on a tremendous annual fund campaign until the end of the calendar year. And we hope that that will be very successful. And we will be counting on all of you and coming to all of you regarding that in the very near future. So thank you again for everything you've done to support, whether it's an online auction or the clothing sale or the golf tournament or a Springfest sponsorship or table or tickets. It all means a lot to us. Thank you.
Thank you, Sue.
So do we have a date for the CEO roundtable?
We do not. We're fluctuating on some dates in October. We're going to talk about again tomorrow.
Okay, thank you.
Tom, was there something going on today or overnight in regards to what we're doing for staff?
So yesterday we did serve free meals to all the staff on the first day.
I know Sue worked all
Yes, she did. Sue and her team were, thank you for pointing that out.
Yeah, because it's 24
Sue,
hours.
Sue and her team, as usual, worked many of the shifts to make sure that food was provided to all the ECMC family, because obviously with dietary having some staffing issues, we wanted to make sure we did that the first day of what we've been dealing with. So.
And thank you to Joe's Deli.
Yes.
Yes.
Did a great job. Did a great job. And thank you, Sue. And again, as disappointing as it is to have to postpone Spring Fest, in addition to obviously the mask mandate, we just felt it was the responsible thing to do right now, based on where we're at. And so we will hopefully be in a better position come next year, and we will be back to full force. So for an indoor event that size. So okay, thank you, Sue.
Happy birthday.
Happy birthday.
Thank you.
From an operations standpoint, the window project's going very, very well. And we started the last zone of the window project and expected to complete that in January. Let's hope the weather holds out so we can continue on our schedule. And thank you, Jim Turner and team, for the just great job they've been doing around that. We mentioned this at the last meeting. We did perform our prosthetic limb surgery. So it's the first one in our region, and those are the positions. We talked about Richard Brandemark. His board approved his ability to come in and perform that surgery. So Dr. Brandemark was very obviously pleased with the surgery and excited about us doing this. And we'll be seeing some press on that in the next few weeks.
Has he done any operations?
They did it last Thursday.
One?
Yep.
Was successful?
Two.
No, there were two done, yeah.
And
Two
successful?
Very
Yeah,
successful.
very, very.
So this really
It's a two-phase operation, though. This is the first part where they put in an implant that has to integrate into the bone, and then they attach the actual prosthesis to it. Maybe 6 months later.
So it's really, groundbreaking, frankly.
Yeah,
I think for especially
revolutionary stuff.
Individuals that have to deal with prosthetic limbs, and I think we're one of now only 3 places I believe in the country that are doing this. So.
Have the UP guys been involved at all?
Dr. Laurie was the one.
And Dr. Anderson.
And the orthopedic surgeons, and it's a collaboration between the plastics. But it was Dr. Laurie who knew this guy because he used his implants for dental. Originally, this guy's father, developed the dental implants, and they've been working. They're phenomenal. And they've been doing those for.
And I think at MedExact, Dr. Hall said he studied under him.
Yeah. So this is that guy's. It's Brainmark Jr. who's developed this. He's adapted that technology that was originally developed for dental implants to develop an implant that will then attach to a prosthesis and give the person, because they won't have to have that kind of thing that goes up over the limb and rubs. It's more independent and flexible.
Amazing.
Yeah, it is amazing stuff.
We'll be hearing more about that in the coming month. We've also been doing orthopedics media campaigns specifically around fracture care. We felt that was an area in which we could have some growth as we studied the market. So thank you to Peter. I thought did a great job in this campaign. We'll be continuing that campaign through the fall. We have some new physicians who started. Andy talked about Dr. Quackish for thoracic, and that service now being in-house, if you will. Dr. Megan Rochester from internal medicine primary will be in internal medicine primary care, and Dr. Evelyn Walsh in neurology. So just to go over the statistics a little bit, obviously lots of red. We have, because of really the lack, even before the issues of individuals having to leave long-term care for nursing homes, we were seeing a slowdown because of staffing issues in, again, congregate settings, mostly nursing homes, but other settings too, which was really increasing our length of stay by a day, which is significant. So that created a lot of issues for us. So as busy as we were, it was really as a result of people kind of spending more time with us, in which from a financial perspective is not good. So we wanted to give you this picture before we give you the financial piece of this, but I'll turn it over to John now, and he can talk a little bit more about the dynamics for August.
Sure. So as Tom said, and as we talked about, being busier doesn't always translate to better operating performance, and August is really indicative of that. So you can see the discharges are actually down from plan despite being so busy and having such a high census. In part, it is due to a reduction in inpatient surgeries as well. But on the next slide, you can really see the net loss that was generated because of that. As Tom said, as we have more patients here longer, we're not getting additional revenue for those patients the longer they stay. But we do have the requisite expense to care for them. So for us, a day's worth of length of stay in a month is roughly additional expense to us of about $1.5 million. And so when you look at this and you see for the month of August, we have a $2.9 million loss. Our budgeted loss for the month was about $1.4 million. So we did really see the impact during the month of August. And as you see here, the average length of stay at 7.8 versus our budget is a little over a day higher than our budget. This number for month to date in September was actually higher. It was up to 9 at one point. So it really is, we've really seen an impact during the month of September. We did mention earlier, talked a little bit about the FTEs as well. You can see here they're at about 3,451. Our budget was about 3,462. So that's why it's in green. That number, just as of the last pay period, because that's a year-to-date figure, but that number as of the last pay period was at about 3,404. So certainly an uphill climb to staff. It kind of exemplifies the staffing availability risk that we talked about.
So we're going to continue to see a diminution of that, say in September, based on the amended, correct?
Yes, we believe so, yes. Just based on those that are on leave. Obviously, we're trying to fill hours with extra shifts, overtime, and call-ins, but it certainly won't get us up to the number that we're seeing today.
Joe, just a quick question. When people go on unpaid, when our staff goes on unpaid leave, do they come back in the order in which they left, or how is the seniority piece? How is the seniority piece played relative to the bargaining unit contract?
What we did in this case is we're gonna allow them to return to their position if they come back vaccinated, fully vaccinated, and within that 30-day period of time.
3 days.
30
days.
30 days, right.
So long as they do that, because we do need staff. So, obviously we shoot ourselves in the foot. We want to encourage people to come back. So we are come back in their same
But
position.
how does that apply to their ability to bid on jobs and or
We're holding
shifts?
Everything's on hold.
So everybody's holding
Yep.
We're holding their
place.
job. Yeah. And in fact, in some instances, we're just double filling them. And, we'll figure that out kind of later because we just need people right now. So we're hiring as fast as we can hire.
Then after that 30, the termination proceeding begins?
Correct.
Okay.
If people already had COVID, do they still need to be vaccinated if they have natural immunity?
Yeah, so Dr. Murray, you can talk more about this than I could, but basically the science would tell you yes, because it's unclear how immune you are if you had COVID based on how sick you were. So go ahead, Dr. Murray.
No, basically that's true. The challenge is that we don't have a good test to measure immunity. So the data we're based on is the experience of comparing how people who are vaccinated do against other groups of people. So there's just not enough evidence to say that it's safe for people who've had COVID to go without vaccination. The evidence is actually if they do get vaccinated, they actually develop much higher antibody levels than people who haven't had COVID. So you could say they get even more benefit from a vaccine. But that's a crude measure of protection is the antibody.
I was in the hospital today waiting, and one of the nurses was on staff that's giving the vaccination to our employees, and she said the emotional part of it is hard for her to have to give that shot where people are crying and really upset about getting the shot. And
They don't want it?
They didn't want it, yeah, but they need their jobs. So she says, she's dealing with it, that she's gotta be the one to give the shot when they're that emotional about not wanting to get it, so.
It's such a contrast to when the vaccine first came out.
Yeah.
Where it was exactly the opposite, people were thrilled to get it, and
Right.
people were thrilled to be working there because they were finally doing something to combat this virus that we, until then, had really no answer for.
Have we seen the variant?
Oh, it's all the Delta variant.
It's all now.
It's pretty much all the Delta
We're doing the gene
variant.
sequencing and only one or two come back not Delta.
And it has been like that since about May.
Is there another variant out there?
There is one out there, but it hasn't really, it's in South America, it's called a mu variant. But it doesn't seem to have penetrated into the United States, which suggests that it may have no advantage over the Delta variant.
Dr. Murray, can you comment on the booster?
Yeah, I certainly can, because I just got mine today.
All right.
Does it hurt?
Not much. But I haven't turned green, or my tongue hasn't swelled. Yes, the evidence for the booster is particularly with Pfizer. Actually, they just did a webinar. The CDC just did a webinar this afternoon. And the Pfizer vaccine has shown some fall off, even in hospitalizations in the over 65 group. It's not huge, but compared to the experience with the Moderna and J&J, it's kind of dipped into the 80%. It's not a huge fall off. Obviously, there has been also a fall off in terms of the prevention of infections, where the efficacy may be down to around in the 60% range with the Pfizer vaccine. So the evidence seems to be that the Moderna and the J&J are holding up a little better than the Pfizer, and that's the reason why, at this point, why the recommendation is for people who've received the Pfizer vaccine.
Thanks very much.
Okay, so I'll get through the next couple slides pretty quickly. I know we're running short on time here. So the month of August on the next slide, you can see, is really just indicative of what we've just talked about. The good news is, though, that we did receive during the month final notification from the SBA of our forgiveness of the PPP loan that we received last year. That's roughly $10 million plus interest that we had been recording. So we did record that this month through what's considered non-operating revenue for us, similar to how we recorded the CARES Act funds last year. And so when you look at the month, certainly was positively impacted by that when you take it all into consideration. But even more so when you look at it on a year-to-date basis. On the next slide, prior to that, we had been running a variance from budget through August of about 10 million. As you may recall, the majority of that was really driven by the impact that the shutdown and the restriction on surgeries for the first 2 months of the year had on us. That was roughly 8 to 9 million of lost revenue, lost margin, quite honestly, in the first 2 months. So the PPP loan forgiveness, although non-cash, really serve to offset the majority of that impact for the year. So when you look at our operations for the year with the PPP loan forgiveness, we're right on track on our budget at this point. COVID update, as usual, bringing that to the board, just tracking it, continuing to track it. So the total impact through August is now roughly about $111 million total impact, including lost revenue and expenses. We'll continue to track this as we go along as COVID exists. Next slide. The last update I'll share, because we haven't been able to provide one, quite honestly, over the last several months, is related to the undistributed funds from the CARES Act Provider Relief Fund. Recently, HRSA announced and HHS announced Phase 4 application process that they intend to distribute about $17 billion of the funds that are undistributed. That application process begins this week. We intend to apply, obviously. There are two components to that. One, they intend to fund lost revenue and expenses for a period of time last year, really July 1st through March 31st of this year. And that's about 75%, and then 25% they intend to fund organizations providers who treat a higher percentage of Medicare and Medicaid individuals. And so, those providers seem to have been left behind to some degree in many of the former applications. And so they're really trying to set some dollars aside. So we do believe, we'll be in line for that. At this point, it's too early to tell how much or when that may be, that may come. We haven't filed the application yet, but when we do, when we do know, we'll bring that back to the board. With that, I'll open it up for questions.
Questions for John and or Tom? Okay, just very quickly as we go through some of the standing committees, I want to make 2 points that I think are relevant to our conversation this afternoon. Number one is that as dire as the circumstances seem to be confronting us, both with regard to the vaccine mandate and our ability to hire people, this is a situation that hospital systems across the country, certainly across the region, are facing. So we're not alone in this, and to the degree that that old saying about misery loves company, it's still very difficult, but it's something that the entire nation, in fact, I would argue internationally, we're seeing right across the board. And in that context, it's an easy segue for me to tell you all, and you know how I've been very public about my estimation of our senior management team. The team has worked tirelessly 24/7 for the past, you could argue for the past 18 or 24 months, but certainly in the past 10 days, it has been an order of magnitude and beyond anything that I have ever seen in terms of managing both care for our patients, the financial integrity of the hospital, and how we present ourselves to the public. And so the board needs to understand, and I'm sure you do, what a tremendous effort it has been, and what a great job Tom and Andy and John and Karen and Dr. Murray and Dr. Grimm have done maintaining ECMC and in that position. And all you need to do is look around even this community and see what lesser efforts have caused in those communities. So Tom, on behalf of the board, once again, thank you and God bless you. And Andy, I can't say enough about what you guys are doing, and obviously Dr. Murray, Dr. Grimm, and Karen, and the whole crew. It's been a joy to watch, even in the late nights and early mornings. And we have created also, for some of you that have been watching TV over the past 24 hours, a media star in Dr. Quattrochi, who has appeared in the New York Times, CNN, and it paid me to watch him on Fox.
It paid me to do the interview.
But I did, and he was great. And he was great, so.
John.
I'm not finished yet, so.
Help here.
So anyway, thank you again, and great stuff, and we just need to figure it out and continue to work it as a team, which you guys have done, so. Well done, everybody. Anybody else want to say anything? No?
Can you recognize me, Mr. Chairman? Can you hear me? Am I still on mute here?
Yes.
Unfortunately.
Yeah. Well, then another story I'd like to tell about John Dandy's. Oh wait, that's for a different audience. Just to remind the board, yes, to John's point about the media, Tom actually, I'm at an undisclosed location. Tom survived a marathon session yesterday with just about every imaginable national media outlet you can imagine. As you mentioned, CBS, ABC, CNN, Fox Business News, Reuters, Associated Press, New York Times, Washington Post, and tonight, if you get home by 6:30 and you turn on PBS NewsHour, you'll see Dr. Quattrochi. So it's been a long haul. He's done a great job. He's really put a great face for the institution nationally. And of course, we're doing all the local media hits too. And I suspect they will continue as this evolves. We know that there's a big court date in October, later in October. So, but we've established some really good connections with these outlets, working with the various producers. They've all been extremely respectful and good to work with. And so it's been a great exercise.
And he didn't mention your name once.
That's how it's supposed to be.
Mr. Chairman, my understanding is he's also going to be in the Kenmore Record Advertiser this week.
Oh, no. Amherst B.
Well, listen, it's,
thank you.
It's been interesting for the institution, obviously really, really important, I think, for us, and put us kind of in a national spotlight, if you will. And then more importantly, the opportunity to talk about the organization and how it's handling the situation. I think it's, we've been trying to elevate our profile nationally through other efforts and boards and conferences and that kind of stuff. But once in a while, you have an opportunity to elevate. And I, got some emails from some other CEOs across the country, elevate the institution, nationally. So it's, and it's all about the people who are pitching in and being able to take care of what we're dealing with right now, which has been cool. So.
Talk about elevation. Talk briefly about the UB search.
Yeah, so we've been involved in Andy, Dr. Murray, and John and I in the UB Dean search, Vice President of Health Sciences and Dean search, and I think there's some great candidates, and I think they've narrowed it down to 2. And I for one, I'm excited about the two candidates and what they might be able to bring to the table. For us, we always fall back to our clinical operations, right? But obviously for all of us in our community, the research and teaching part is equally as important. So hopefully, I think both these candidates would be able to elevate us on all 3 of those fronts. And it's been great that they've included us as part of that and actually put us in front of 5 candidates. So that's been great.
I was going to add that unlike some of the other community searches, President Tripathi has done, I thought, a remarkable job in bringing literally 5 candidates here, all of whom could have been great in this job, and now, as I understand it from him, down to 2, both of whom are really off the chart.
Mm-hmm. Mm-hmm. I mean, their academic research credentials are off the chart, and Nancy Nielsen and these candidates are talking about boards and people, and that is just another level. And they're all know each other very well. So
my Tom and Andy and I and Dr. Murray have been participating in the various levels of the search, and in one of the interviews, the candidate was talking about his participation on some national or international medical committees. And he very often said, yeah, and it's, I asked, I said, what committee is that? And he said, well, it's the Nobel Committee.
Hello there.
Like, as in prize? And he said, oh yeah.
How are you?
So that's the quality of the candidate. Anyway, candidates. So more to come on that. And obviously has a large impact on what we do.
Yes.
Mike Seaman, anything else on finance? No. You're good? Mr. Bennett on buildings and grounds. Is he?
Yeah,
still with us?
Yeah. We had our first monthly meeting in 3 months. Some of the things that Tom mentioned in regard to the windows, the $22 million is coming to a conclusion, and it really looks good. One of the things that they were able to do in-house is we had new landscaping and decorative stone around our new department. But I think one of the most interesting things to me is this kitchen tray line where they're putting in another line. So they'll have 2 lines that these are the lines that they use to prepare the food for the patients. And as Andy said in our meeting, it's going to provide a better quality of food because it's going to be there easier and warmer. So I look forward to that. It's working on it, and I hope to have it in by a couple months. So that was our meeting. It's good, and everybody joined in. Thank you.
Thank you, Mr. Bennett. When that tray line is operational, we're gonna have another big party.
Go for it.
Yes, we will.
Bishop, HR.
He's not on
I
anymore.
don't think it's on right.
No, John? Mike?
Yeah,
QI?
thanks, John. We, in our quality information and patient safety committee meeting, we had a report from Dr. Christina Sanders on the Quality Leadership Council summary. We also had a presentation by John Cumbo on our health information technology and how those are coming along, and also a report from Donna Jones on bariatric services. And I don't know if Charlene is on and has anything regarding the regulatory report that she reported out. That's it for me, John.
Thank you, Michael. Charlene, anything else?
She's not on.
She's gone. When is Leapfrog coming back? Soon, yes?
Yeah, be later in the fall.
Okay. Is there anything else for the good of the order?
Your attention, please. The K Cafe food truck will be at the employee.
Right on cue.
Truck is out.
Timing is everything.
For those of you that want to hit the food truck, I'd be happy to entertain a motion to adjourn. So moved. Is there a second? All in favor?
Aye.
Thank you. All right, please stay safe. We are adjourned.